Hi, I'm Jane Goodall. This is Charles, who's consented to an examination of his hip and groin today. He's no underlying pathology and is fit and well. So we begin our examination with an inspection anteriorly. We're looking for any scars indicating previous surgery or trauma, any swelling, any erythema, and we're looking generally for signs of atrophy, hypertrophy, fasciculation, general alignment, pelvic tilting, femoral anteversion, a valgus or varus at the knees. Can you step apart, Charles? Any pes cavus or planus, which could increase the internal rotation at the tibia, putting stress through the patellofemoral joint and causing malalignment at the hip joint, which further stresses there. So we then look laterally at the curves, in particular the lumbar lordosis, which may be increased, exaggerated with a fixed flexion deformity. Just turn around, Charles. Any signs of scoliosis. Obviously we're comparing bilaterally always, looking at the muscle masses and the gluteal folds. That's great. And then turn around for me. Okay, so I just want to assess Charles's gait and his movement pattern. So if you walk slowly towards me, Charles, and then turn around and walk back again. So I'm looking for smoothness and symmetry. If there's any antalgia, a waddling gait with swaying from side to side could indicate a weakened gluteus medius. Any foot drop and high steppish gait could suggest a common perineal nerve palsy or a sciatic nerve palsy. Okay, Charles, can you walk towards me on tiptoes and then walk back on your heels? So we're assessing 90% of his neuromotor function. It looks like he's got good integrity there in his nerves and muscles. That's lovely. And then if you can stand on one leg and then squat down 90 degrees, Charles. So we're looking for any internal rotation in the knee, any pelvic dropping or lateral swaying in the torso. And then we could repeat this on an unstable surface, such as a cushion or a mini trampoline, to further assess if there are any balance or coordination problems there. It's great. So if you just move a little forward, thank you. So I want you to now just stand on one leg and bend back towards me, Charles. Any discomfort?
No.
This is a stalk test. So if there had been pain on the ipsilateral side of the weight-bearing leg, that would be positive and indicate a spondylolysis or sacroiliac joint dysfunction. The next test we're looking for is the Trent-Danberg sign. So if you just stand on one leg, we're looking for signs of the pelvis dropping on the side, just relax there, of the unsupported leg, which would indicate a weakness or painful gluteus medius, one that's least mechanically compromised. Okay, Charles, if you can sit on the table. Okay, so we continue looking at the back, and we're just palpating spinous process. There's any tenderness there, and into the sacroiliac joints and the lateral muscle masses there. Okay, Charles, if you'd like to bend forward for me, please, and then we want to see if there's any scoliosis or an exaggeration of the scoliosis that we found, and then bend back into my hand, so bend backwards. That's lovely. And then if you want to twist around to the right hand side and round to the left hand side, and then bend side to side for me. So we're looking for flexibility and symmetry throughout range for all directions. Okay, so do you want to just lie onto your back for me? So we're going to do a quick neurovascular screen. I'm going to start off with a provocation test, the sciatic nerve. You want to just slowly lift this right leg for me, Charles. Any discomfort or pain going down to the legs? If there were, what we do is dorsiflex the foot, and this will exacerbate, if it's positive, it exacerbates symptoms, and equally plantar flexion of the foot and flexion at the knee would relieve those symptoms too if it was positive, and it could indicate a herniated lumbar disc or an impingement syndrome. So next I'm going to feel for temperature, look at capillary refill. Lovely. Check the dorsal pedal pulses, the posterior tibial pulses. Okay. Distal monotone. So Charles, if you want to just push your feet up into my hands, L4, and the big toes push up, L5, and push down. That's lovely. And then sensations, so I'm just going to stroke, so you just tell me if it's equal both sides. Close your eyes.
Yeah.
Same.
Yeah.
L5.
Yeah.
S1. That's lovely. Okay, so I'm then going to palpate around the anterior groin region. This would normally be exposed, and I'll start with the iliac crest. Any tenderness there?
No.
Could indicate an apophysitis. The ASIS, where the sartorius inserts. Any tenderness there?
No.
Just inferior to it, the anterior inferior iliac spine, where the rectus femoris inserts, and nothing there.
No.
And I palpate medially along the inguinal ligament to pubic tubercle and the pubic symphysis. Any tenderness there could indicate an osteitis pubis. We would also observe supramedial to the pubic tubercle. If there was any bulging there, could be an inguinal hernia. Inferolateral to the pubic tubercle could indicate a femoral hernia. Plus we could locate between the ASIS and the pubic tubercle midway, and just inferior to the inguinal ligament is the femoral artery. If you palpate there, it's normally strong. If it's diminished in any way, this could indicate a partial occlusion of the common iliac artery, or the external iliac artery. Okay, we can also palpate, just externally rotate the leg, and palpate with the gracilis from the pes serine into the adductors and up to the pubic rami. If there's any numbness medially, that could indicate there's an obturator nerve impingement. That's lovely. Okay, Charles, can you lie side facing me, please? So then we can palpate the greater trochanter. If there's any discomfort there, that could indicate a bursal problem. It could also indicate an insertional pain with the gluteus medius, or also a snapping hip. No problems there when palpating? No. We palpate down to the tensor fascia lata, iliotibial band, down to the girdus tubercle, hamstrings, up to the ischial tuberosity tenderness there, where the tendon inserts. And also just proximal to that is the sciatic notch, where the sciatic nerve emerges. That can sometimes be irritated there, as it can midpoint between the greater trochanter and the ischial tuberosity. There's a herniated disc or piriformis syndrome. Line to your back, Jules. Okay, so I'm just going to combine now passive movements with resisted isometric tests as well. So just let me move your legs, Charles, just try and relax. So passive hip flexion, we're looking at about 120 degrees. Pull up towards you, Charles. That's the iliopsoas. And then if we just, let's then push your legs straight up, test the quads. Great. And then we can feel for, just relax your leg, Charles. Internal rotation. So that should be about 40 degrees. And we're feeling for range, quality, end feel of movement, any crepitus. And then Charles, push outwards with your foot, my hand, that's lovely. And then external rotation, and then push into my hand that way. That's lovely. External rotation should be 45 degrees. That's great. Relax the leg down. That's lovely. And then we're going to abduct again, 45 degrees. And this time, Charles, push outwards into my hand. Yeah, that's lovely. It's gluteus medius and the tensor fascia lata. And then we're going to adduct. Normal is about 30 degrees, and then push into my hand, Charles. That's lovely. And relax it there. We can test for the sartorius by sliding his foot up his shin. So just push up with your foot, ankle, and resist external rotation. That any problems there could indicate a sartorius problem. Okay, Charles, can you lie onto your tummy for me? So to check extension, if you just lift this leg up off the table, that's great. So between 10 and 30 degrees extension is normal, and then push straight up into my hand, and that's resisting, that's the hamstrings. And then we bend the knee and push up again, to test the gluteus maximus. That's great. And relax there. Lie onto your back, please, Charles. Okay, so we then go on to doing some special tests. The first one is the Thomas test. I'm just sliding my hand under Charles' lumbar spine. And then if you can bring these both up, Charles, for me. And then if you just relax this one and let this one just extend out. So I'm looking for signs of a gap between his leg and the table, and also if he lifts his back and takes the weight off my hand, which would be indicative of a flexion contracture of the hip. And repeat it on the other side. The next test I'd like to do is the Faber test, which is an acronym for flexion, abduction and external rotation. Okay, so I'm just going to rest that. I'm going to stabilise your pelvis while I'm doing that. I'm going to press down a little bit. Any discomfort there?
No.
So if there were restricted range of movement and pain in the hip, could indicate an intra-articular hip problem. If there's pain primarily in the SI joint, it would be more of a sacroiliac joint dysfunction. The next test is the Fadia test, which is flexion, adduction and internal rotation. Any problems there?
No.
If there was anterolateral groin pain, that could be indicative of a femoral acetabular impingement. If equally it puts attention on the piriformis muscle, which is also implicated with sciatic nerve impingement. So to test that, what should we external rotate, flex the hip, and then just push against my hand, Charlie, and resist external rotation, and that would indicate the piriformis muscle. That's lovely. So the next test I'd like to do is to test for stress fracture. So I'm going to percuss through the heel, down through the femur and the greater trochanter. Okay, and if the shock exacerbates any pain, it could be indicative of a stress fracture. But more significantly is the extremes of internal rotation and external rotation. If they produce a deep anterior groin pain along with the percussive pain, then it is suggestive of a stress fracture. We should be looking at a bone scan or an MRI. So the next set of tests are to look for a snapping hip. Common causes, iliopsoas, greater trochanter, and we've also got intra-articular pathology, which you're talking about a labral tear or a loose body. So to test for the iliopsoas, which passes over the pelvic brim to insert onto the femoral neck and the lesser trochanter, we flex, externally rotate, and then as we bring it out into extension, we internally rotate and we palpate for a click, or we can hear a snap or a pop, and intra-articular, palpate into the groin, and then we're going to flex and take it through all its ranges, hoping to impinge the labrum against the acetabulum, and then we do the same that way. Lovely. Onto your side facing me, Charlie. And for the greater trochanter, we can just lift Charlie's leg, so just relax there, Charles. And we can put it into internal rotation and external rotation. Again, feeling for that snap or click, and then extend, abduct, and then gently lower it down. It should be smooth. If it's not, and it doesn't quite lower down as well, we are looking at a iliotibial band contracture there as well. And that would complete our examination. We could, if requested or indicated, do a full neurological, and we could look at examining more comprehensively his back and his knees, and request further imaging if necessary. Thank you.